Okay, great. Thank you very much, Dr. Kloner. Good evening, everybody. The study I'm going to describe today is something that is currently ongoing, so I don't have any results to show you, but just to show you where our thinking behind this study and also the progress we made so far in recruiting into the study. So I think we are all aware that with the increased availability of interventions for treating patients with myocardial infarction, clearly survival after MI has gone up. But a consequence of that is that there is also an increase in the incidence of post-MI heart failure in patients who, despite reperfusion strategies, develop significant cardiac injury. And this is due to the phenomenon of remodeling, which I'm sure you're all associated with. So post-MI heart failure is associated with increased mortality and has a major impact on quality of life of patients, and clearly therefore creates a significant burden on healthcare systems. And any mechanism we have to alleviate post-MI heart failure is certainly going to be an important thing going forward, given the increasing incidence of this problem. Most of you are also probably familiar with this concept of why people get heart failure following myocardial infarction. Clearly an important issue relates to the loss of muscle tissue, but there's also a process of remodeling whereby even the non-infarcted part of the heart develops problems and related to inflammation, related to reperfusion injury, and to myocardial hypertrophy, which is an important component of post-infarction remodeling. We became interested in this because of observations showing that RIC may have or remote ischemic conditioning may have an issue on remodeling. Most of you are aware that there have been a number of studies showing that remote ischemic conditioning causes changes in the heart in terms of neutrophil adhesion, which is an important component of remodeling in the heart. There have been studies which have shown long-term benefit of post-conditioning in this setting. But the study that intrigued us most was one published last year, or a couple of years ago, from Andrew Reddington's group, showing that not only does an acute episode of RIC at the time of the infarct results in reduction in infarct size, which has been shown in a number of studies in different ways, but if you did this repeatedly after the infarct has been sustained, you may get additional benefit. So there seems to be a partitioning between the benefits in terms of reduction of infarct size, which would happen with the sort of single episode of RIC that you might give at the time of the infarct, either before, or well, not really before, but at the time or just after, and the possibility that you may get benefit if you applied RIC in a serial manner for some time after the heart attack. And they showed in this study that the benefit was due to a potential impact on remodeling. And as I said, because hypertrophy is an important component of this, we were intrigued as to whether RIC may have a benefit in terms of reducing hypertrophy. So in an experimental model that we set up in Leicester, we looked to see whether if you took plasma or serum from patients who've had an episode of RIC, so these are healthy volunteers who had RIC given to them in a standard fashion, whether you could reduce in a cellular model of hypertrophy, whether you could reduce the hypertrophy that happens. So we took these cardiomyoblasts, which is a cellular model of cardiac cells, and endothelin-1, which is a stimulant of hypertrophy. As you can see on the bar chart on the right-hand side, that if you expose these cells to endothelin, you have an increase in terms of cardiac size. But that if you treated these individuals with serum from having undergone either a sham RIC, or particularly if you have RIC, then you see a significant attenuation in terms of the endothelin-induced cardiac hypertrophy. So this is not something that's really been investigated further. Most people have focused obviously on the acute effects of RIC on cardiomyocyte survival, but there seems to be some benefit in terms of additional things that RIC may do to cardiomyoblasts and cardiomyocytes in terms of hypertrophy and other processes. And we mapped this particular benefit to the fact that this is due to activation of an AMPK signaling pathway within the cardiomyocyte, which results in attenuation of the endothelin-related cardiac hypertrophy. So given this observation in mice that Andrew Reddington's group had made, and some of these sort of preclinical cell-based studies that we've done suggesting that RIC may have benefits just beyond cardiomyocyte survival, we thought that the DREAM study would be something that would be a sort of early phase 2 study to see if this translates into any clinical benefit. And so the hypothesis we wanted to test in the DREAM study was whether repeated remote ischemic conditioning for 4 weeks, which is somewhat parallel to what the mouse study had done, post an ST elevation MI, positively influences LV remodeling. Okay, so this is the basis for the DREAM study. And it's a phase 2 randomized trial, clinical trial of chronic RIC in patients with post-MI LV dysfunction. So the inclusion and exclusion criteria for the DREAM study are fairly standard in this context. These are patients who've had a first STEMI, who've undergone a successful primary PCI, and have been shown very shortly after their STEMI that they had significant decrease in LV function, so it had an ejection fraction below 45%. And the exclusion criteria are fairly standard as well. There were no further planned coronary interventions. They didn't have any significant comorbidity or illness which may prevent, have an influence on their mortality or may have influence in terms of their follow-up. And they should not have had a prior history of documented heart failure. And because we were going to use an MRI-based endpoint, these people should not have had an ICD or resynchronization therapy in place. The plan in this trial was to do a sort of 50-50 block randomization to either treatment for 4 weeks with RIC or a control group, and we tried to stratify the patients on the basis of the age and gender, and also the infarct location, whether it was anterior or in a non-anterior territory. And the plan was to give these people 4 cycles of upper limb RIC administered daily for 4 weeks by participants in their own homes using the Cell Aegis Auto-RIC machine, which many of you, I'm sure, are familiar with, which has become available in the last couple of years, starting on day 3 post the STEMI, to try and partition away this effect from any benefits that relate to myocardial salvage from any RIC that's given immediately post the infarct. So this was done slightly later in this basis. So the intervention is 4 cycles administered daily of 5 minutes of inflation interspersed with 5 minutes of deflation, which is fairly standard RIC protocol, with the treatment group receiving a blood pressure inflation of the cuff to 200 millimeters mercury, and the patients who were the control arm, and I'll come to this in a moment, which is to do with blinding in such a study, is to give them a similar machine, but only inflated to a maximum of 10 millimeters of mercury. So they applied it in the same way and had a minor inflation of the machine. And the patients were not told, I'll come to this. This was discussed with the ethics committee of the application, because as you know, with these sorts of interventions where the sham or the placebo treated group get nothing, and we know Simplicity is a good example of this, the renal denervation trial, that if patients receive a treatment and the placebo group get nothing, then there is a fairly potential bias in terms of a placebo-based effect. So we wanted to give all these individuals a machine to inflate in a way they would do it for the active group, but they were not told that they were actually having a sham procedure. So there is a partial blinding of the thing. The primary outcome was one we debated what we should be, but we eventually chose on a delta change in the LV ejection fraction, because it's to do with remodeling from the baseline gadolinium-enhanced cardiac MRI scan, which was done after the patients had been accepted into this trial on the basis of a transthoracic echo based diagnosis with ejection fraction below 45%. And so this MRI scan was done between 2 and 5 days post the infarct. And then, having received 1 month of RIC therapy, the patients then had a further MRI scan at 4 months post-STEMI to see whether there was a change in ejection fraction. And I'll come to in a minute to how we power this study, because we have a lot of evidence based on other trials we've done in Leicester as to the natural behavior of LV ejection fraction in patients post-STEMI. So we've done some studies, so we knew, because often in patients immediately after the infarct, the LV ejection fraction is depressed, but it naturally improves, and what we wanted to see was an improvement on top of this. There are a number of secondary outcomes, including the left ventricular volumes on MRI scan, the final infarct size measured at 4 months using gadolinium in these patients, a number of biomarkers of cardiac function, and patients' quality of life, and of course MACE outcomes, although this is not a study that is really geared towards reduction or an expectation of any reduction in MACEs in these individuals. And the power calculation, as I said, we based our study was on local work we've done about looking at the time course of the natural improvement in LV ejection fraction over time in a study population similar to the one that we're going to randomize, and also on published data. And we've gone for, it is a phase 2 trial, so we've gone for a 5% or greater improvement in LV ejection fraction over and above the natural recovery we expect over 4 months. And the data we have suggests that if we had 72 participants in the trial, then we would have a power of 80% for an alpha of 0.05. And we plan to recruit 90 patients into this trial to allow for a dropout rate which inevitably would happen in such a post-STEMI population. A note on blinding. So participants are blinded to the treatment arm. So when we go and see them, we say we are doing a study of this particular protocol. We don't tell them that it requires arterial blood pressure inflation. We just say them they have to apply this machine to their arm, and they have to press a button which will inflate it, and they've got to do it 4 times every day with a 5-minute break in between. So patients are not aware that they are in a placebo arm or not. And this is quite we think this is important in such trials, simply because if the patient in the placebo arm had gone home without any machine, there would potentially be a question of bias. Clearly the investigators administering the machine and overseeing the trial are not blinded, but the primary endpoint is based on an MRI scan analysis where the investigators are assessing the MRI scans that are completely blinded to which group the patients are in, and indeed they won't even know the sequence in which the MRI scans have been done, so that they will either look at the 4-month or the first 1 month one without knowing. They just have to do the calculations on these things. So this is the timeline for a DREAM participant. They have their STEMI and a primary PCI. We approach them usually within 24 or 48 hours after this, and they have undergo transthoracic echo. And if this is below 45% on the back of that, and they're willing to participate, they're randomized. They have their baseline bloods done and have a baseline CMRI, which we know does not fluctuate that much between sort of day 2 and day 5. But on day 3, they start their first RIC in hospital, and they're told how to do it. And then they go on to do this for 28 days, and they're followed by telephone at this stage, and they come back at 4 months for a final assessment, including a full cardiac MRI scan. When we first started this study, which is just over 15 months ago now, we thought we would recruit. We are a big secondary referral center, and we thought we saw a lot of STEMI patients, and this would be easy to do a single center trial very easily within a year or so, because we see a large volume of patients. We have some competing studies going on, but we found it quite amazingly difficult. We are beginning to treat patients much better with infarcts. So the number of patients, we have a lot of infarcts, but the patients we actually have all the criteria for inclusion, particularly ejection fraction, and have none of the exclusion criteria, was quite low. So we screened over 680 patients now, and really only been able to recruit a small proportion of them to meet, which fulfill our criteria. So we are about halfway through the study, just over halfway through the study now, having recruited 51 patients. We expected a dropout rate for various reasons, and 9 have dropped out so far, which is about in time with what we expected, just under 20% dropout rate. 32 have completed the trial, and because of this recruitment issue, we've now got 2 sites adjacent to us in Leicester who are also enrolling, and we hope that by October next year we'll have definitely recruited, if not much before then, and completed this trial therefore. So in summary, and this was not a study that we completed, it's just a proof of concept study to see if RIC has benefits beyond this acute infarct size reduction, in that we know that RIC is effective in infarct reduction in the context of STEMI, and I think that's reasonably well established now, although, as Professor Kloner said, we need really big studies to really nail that completely. Animal studies suggest repeat RIC may have additional role in post-MI remodeling, and some of our preclinical stuff using cell culture suggests that in fact there's a cell-based molecule that RIC produces that clearly has an effect on cardiac hypertrophy in an experimental model. And so DREAM is the first in men trial to address the question of whether this phenomenon of repeated RIC after STEMI reduces the possibility of remodeling. And we've become aware since we started RIC that there's actually a complementary study being done by Andrew Reddington's group in Canada, which is now underway. So if we see something and they can repeat it, then I think that obviously would provide additional validation. So I hope that gives you a summary of where we are with RIC, with the DREAM study. Thank you very much. Yeah, and I now look forward to the criticisms of the study.
Well, take some questions. Let me start off by asking a question. So I assume that these patients are going to be on usual medical therapy, including ACE inhibitors, ARBs, or beta blockers.
Yeah. So they're
on top of.
This is on top of this, and as I said, I think one of the reasons for doing this was that with those drugs on board, we have very good data about what happens to LV function measured by ejection fraction and other things over the course of the trial. So we know what the variability is in recovery.
So you're looking for an added benefit on top of usual therapy.
So any reason to do every day? Did you think about doing every other day, or you want to go maximum full dose, and if it works then you can go lower?
Yeah, I mean we don't even know whether every day is going to work, so we might as well go for what was done in the mouse model basically, and I mean there's obviously evidence in the context of just single episodes of RIC in terms of benefits, in terms of cellular effects, that it lasts for more than 24 hours. So whether there's tachyphylaxis with this, we don't know either. So there's a possibility that if you do it repeatedly, you might actually create tachyphylaxis. So we don't know that either.
How about measuring blood pressure? Are you continuously measuring blood pressure throughout this time to evaluate the effect of RIC on blood pressure?
No, we're not. I mean, we'll check blood pressure when they come back for their assessments, in clinic. But we're not assessing blood pressure through the course of the trial. I mean, do you see that as an issue?
Well, you would want, if you were to measure blood pressure, I think you would have some insight that otherwise you might not get that. If there is a trend.
Okay, as to why if you see a benefit, that it may be blood pressure driven.
That's right.
Yeah. No, we'll know their blood pressure at 38 days, and again at 4 months.
Better than not having at all comparison, but it is. I think it's important. Endothelial function is also helpful. Those are things that can give you additional light to the depression.
What are some of the reasons for the non-dropouts?
So I mean, it's a curious thing that a couple of patients have dropped out because when we did the cardiac MRI scan at 4 days, they had a mural thrombus, and they decided they didn't want to continue. They had to go on proper anticoagulation after that, and they decided they didn't want to do this. And I think, as physicians, we don't, because we don't do MRI scans on all these individuals. All of them had a transthoracic echo, didn't show a mural thrombus, and then we had an MRI scan, and they had a fairly obvious mural thrombus, and they decided to drop out. I think it's to do with logistics of just not wanting to continue.
Has anyone dropped out because of complaining of discomfort of having the
No,
blood pressure?
no, we've had
So that's
nobody-
not been an issue. I think that's
That,
important.
yeah, that is not. I think that's a good point.
So are you measuring the, like, petechiae or other, problems with
Yeah.
bleeding and
Yeah, we are, and we've not lost anybody because they are on dual antiplatelet therapy,
Right.
in this
That's
context,
that's
and
what
so
works.
but we've not had anybody drop out
But
for that
you're
reason.
monitoring
Yeah,
for
we're
those
monitoring. Yes, I mean
skin
we're monitoring it by telephone contact with these individuals. We're not monitoring it by them coming back to the clinic, but we do speak to them at 3 days after they leave the hospital, a week later, just to make sure they're doing this. The good thing about the Cell Aegis machine also is that it does record whether the patient is actually doing the treatment.
right, so there's
So there's
some compliance.
some
there.
compliance. There's obviously a compliance issue as well.
I noticed that they don't have blood pressure
No.
measurement, and that's something
Yeah,
that
but you don't know the machine's being used.
yeah.
Dr. Olekatan?
Quick question. What's the rationale behind 200 milligrams? Why did you?
Yeah, no, I completely agree. And in this context, one could argue that most of the post-MI patients won't be much above 140 anyway. I think it's just to achieve a proper ischemic conditioning. It isn't rational.
Yes.
Sorry.
Can you speak up? It's a little hard to hear.
You'll be looking at the mitochondrial level as well, or just the cardiac function?
You're looking at
Any
myocardial function.
yeah, molecular mitochondrial studies.
No, molecular mitochondrial studies in where would you want to do that?
The cardiac cells.
Like biopsy?
Yeah.
No, I don't think.
Not,
they-
I think we'd have a big dropout rate at that point. So,
Just endothelial cells.
Right, or circulating endothelial cells.
we haven't done
Yeah,
that
can
yet.
you
I'll-
comment on that? How you would do that? You draw blood and extract endothelial cells and try to look into mitochondrial?
With that, we know how to say that they look mononuclear cells, they probably have the same mitochondrial function as the mitochondrial functions in other tissues.
That's a good suggestion. I think as you go forward, those are the things that will give you insight. If you find
I think at this stage, clearly, we won't. If you see an effect, and particularly if the Canadian trial also sees an effect, then I think it will be then all the mechanistic stuff
and this
would
could be
come.
done in a blood bank, possibly just draw blood and do it later.
I mean, we've got a lot of. We are storing blood samples on these individuals, but not the sort of samples that you need for mitochondrial function. I don't think. Yeah. So we're going to do a blinded BNP levels are going to get measured on all these individuals, and a number of. I think I had a slide of a number of molecules, also collagen turnover in these individuals, to just see if we can see anything in the blood. Sorry,
These people after hypertrophy and cell function have that serum assay.
yeah, no, I think you're right. But the evidence we have is in cell culture at the moment. But we've got plasma samples and serum samples stored away.
So does the 10 millimeter inflation is not going to be painful, correct?
The 10 millimeter.
Yeah, it's not. It's not going to be painful.
And does that concern you in terms of sepsis?
Well, the question is, when does RIC start to play in? Yes, so whether 50 millimeters of mercury, does it start to play in there? I'm not aware of anything apart from people saying they've gone suprasystolic blood pressure and assume that you get ischemia. But would 40 or 50? Do you know whether subsystolic blood pressure produces?
Well, you expect no flow as opposed to ischemia. You can't reach that.
But is it to do with? We call it ischemic, right? But is it to do with no flow? So I'm just trying. I mean, you're an expert, so I just don't know whether just raising it to 50 or 70 millimeters of
I
mercury.
haven't
Yeah,
seen
I
a
don't
good
think-
dose response, but I think that the idea is you're going to get ischemic, you've got to occlude the artery.
Blood
So,
flow,
I mean, so
yeah.
you're shooting for 200 millimeters of mercury. You're going to occlude everybody's artery. You're not going to have to worry about
Yeah.
not achieving RIC. I think.
Yeah.
Is there a question?
I think all of these molecular studies would be good after when they find something, and then we go try.
Question back here.
I'm an imager, so let me give you two comments on MRI. In fresh MIs, you probably have to look at the microvascular structure and compare the difference in the volume of microvascular structure. Second suggestion would be, do you actually measure the volume? Many
Yeah.
years ago, we published a paper that allows you provides shape index. You can actually measure the shape.
Okay.
Changing from bullet shape to oval shape or to spherical. If you're interested, I can send you.
Oh, that'll be. We'll be certainly be interested.
We published paper in 2005. So,
Okay.
Basically, you can utilize this shape index.
Okay.
Compare it as well as direct measurement.
Yeah. That would be excellent. Thank you very much, because clearly we would want to do that. Regarding microvascular obstruction, we are looking at that. So that is part of the. No. It's a full gadolinium based analysis.